Hello, everybody. Good evening. Thank you for joining us on a Tuesday night to talk about a topic that's very near and dear to me, and that's basically everything you need to know about cataract surgery. And like I was just introduced, I am a cornea and cataract surgeon at the Gavin Herbert Eye Institute. Yeah, also, I know everybody's going to have questions. I look forward to answering them. It always creates a lot of great discussion. So if it's a question you feel like you can't hold until the end, just type it into the chat, and then we'll make sure we catch it at the end. Otherwise, we will have some time at the end to address questions, whether they're questions you came into this lecture with or from some of the topics and slides that we talk about to make sure everyone's questions are answered. So very briefly, who am I and why am I giving this talk? This is just a little background of where I did my training. And you'll notice that I did my cornea fellowship here at the Gavin Herbert Eye Institute back in 2016. That's actually when I became board certified. I took a position at Emory University where I was associate professor for 7 years, and then was lucky enough to come back here a little over a year ago. And so I love ophthalmology. For many reasons, as you'll learn tonight, from one of my favorite surgeries, which is cataract surgery, we really can change and make an impact in someone's life. And so you'll see that, and I'm going to present some data to actually back that up. Also, I feel like with ophthalmology, we have such a great opportunity where we can, whether it's locally or internationally, do work to really help make an impact and change people's lives with global ophthalmology. So here are some photos of my other second favorite hobby in ophthalmology, and that's global ophthalmology, and some of the projects that we do here at the Gavin Herbert Eye Institute in other countries. And that's obviously a topic we can save for another evening. So here are the objectives that we're going to hit tonight in this talk. Very briefly, what is a cataract? Everybody's heard of that, but is it normal? Is it abnormal? When does it happen? And how does it form? Why does a cataract form? We're also going to get a little bit deeper into the impact on people over the age of 65, and how cataracts can impact day-to-day activity, focusing on things like driving. And then we'll review what's really important with a preoperative evaluation for cataract surgery, the whole process of cataract surgery, and then also kind of tie things together with postoperative care, including reviewing some of the potential complications that can go with cataract surgery, and then kind of close it with a long-term situation that can occur after cataract surgery, a posterior capsular opacification, which we'll discuss and go over the treatment of that as well. So very briefly, I think it's really important that we talk about the anatomy of the eye before we delve deeper into this evening's topic. And so this is basically a cross-section of the eye, the front of the eye being on the left of the slide, and then the back, or basically where the brain sits, to the right. And so we actually have a clear layer in the front of the eye, which is called the cornea. And so that's actually what we're looking through when we see someone's pupil. And an interesting fact is about 2/3 of the eye's ability to focus comes from where the tear and the cornea meet. And then the remaining power of the eye comes from the lens, which is behind the pupil or the colored part of the eye. And so when we're first born, it's very jelly, elasticy, so it can kind of change shape, going from kind of being round to flat. And that's kind of the ability of the eye to be able to accommodate and see things from far away and up close. And this lens is basically what turns into a cataract that we're going to get into tonight. Behind this lens, there is a jelly-filled cavity, which we refer to as a vitreous cavity. And then we have the retina, which lines that. And that's basically what images are focused on. And that is transmitted into a nerve signal that goes basically through the optic nerve to the brain. And that's basically in the occipital lobe is how we see. And so you can see these are the many different parts that are important with vision and being able to see. However, you can see that if that cataract is not clear, it can really impact our ability for images to come through and be focused on the retina and basically go to the brain so we can perceive vision. So one of the most common presentations to my clinic is, "Doc, I'm here to have my Cadillac removed." So yeah, it's a joke. It's not really a Cadillac, it's a cataract. But I'm sure everybody has a new joke they can use now at the dinner table. But it's a common one that comes into my clinic. And so, what is a cataract? So a cataract, when we were talking about that lens that's inside the eye, it's the normal opacification or clouding of the natural lens. And so, actually, this process can start as young as the age of 40. Now, there are other conditions, whether it's trauma or metabolic conditions or side effects from medications, where cataracts can actually start sooner than 40, but we're talking about an age-related cataract. And as this cataract progresses and gets, more opacified, more cloudy, more yellow, it impacts our quality of vision and ultimately can greatly impact our ability to even see in general. This is something we can kind of monitor with the dysfunctional lens index. And so as that clear lens becomes more yellow and opacified, it causes scattering of light and issues with focusing. And so 90% of the time, cataracts are an age-related consequence. I just previously mentioned some other conditions that might be related. But some of the potential risk factors outside of aging include increased exposure to UV light, diabetes, trauma, and then also various medications of particular long-term steroids can cause cataracts to progress faster. So just trying to kind of show you what a cataract really does in terms of impacting vision. This is just a picture, obviously, of two young boys here holding balls, and we can kind of make them out, but we can't, the contrast, the colors, those are greatly affected. So this is someone with like a moderate to severe cataract, how they're perceiving their vision. And then here is a slit lamp photograph to show you the most common type of age-related cataract is a nuclear sclerotic cataract. So here we have that pupil, and this pupil has been dilated by us because we want to examine the size so you can see what the pupil looks like dilated. And then if we look in that space behind the pupil, and this is kind of our slit beam under a microscope, we can see here is the front of the cataract, and then here is the back of the cataract. It's hard to tell from this image, but it's actually pretty dense and hard. But you can definitely see this yellowing of this lens, whereas a normal lens before a cataract would be clear. And so this is kind of how the normal age-related cataract that slowly progresses does look when we're examining at the slit lamp. And just throwing some random cataracts here, there's a potential for a congenital type of cataract, which is a posterior polar. So the cataract only forms in the back layer of the lens. There are also, either from trauma or a cataract that's been progressing for so long, we can get a hypermature cataract where it's basically almost like a white rock. This is a type of cataract that I encounter commonly outside of the US when I'm going on humanitarian trips, but we do see this type of cataract here in the United States. Actually, today we had two of these type of cataracts on different patients. So what are the symptoms? So patients always ask me, how do I know my cataract's progressing? It's obviously blurring of vision. So this is going to be, maybe noticing difficulty with reading at first, commonly, issues with driving, a prescription that's continuing to change. So you get a pair of glasses, they work great. 6 months later, they're not as clear. You get an updated pair of glasses, and that continued progression and change. One of the most common presenting symptoms is glare, especially when patients are driving at night. And this is due to that cataract, that opacification, that yellowing, when basically light is hitting the cataract, and at nighttime our pupils are dilated, we get more of that scattering, and that leads to the glare. And nowadays, with more advanced LED car lights, they're much more symptomatic earlier. And then overall, same kind of process, but affecting our contrast. So being able to tell colors, seeing whites and yellows and blues and being able to tell the difference. And then over time, as a cataract gets worse, we lose best spectacle correction, meaning that even with glasses, last year with a change of the prescription, our patient may be able to get to 20/20, but now the cataract a year later has progressed, that the prescription not only has changed, but their best corrected vision with glasses is 20/30 or maybe 20/40. And so at this point, basically, we're making the optical shop a lot of money, but we're not really helping our patients. And eventually, if the cataract continues to progress, it will get to the point where it becomes hyper mature, and even turns into a dark, almost like a black rock cataract. That is not something I have seen here in the United States. I have seen outside of the US, but this kind of being the reason of why cataract surgery is important to have done when our patients are having symptoms. So, how common is this? One out of every three have some sort of vision loss due to cataracts by the age of 65. And this vision loss can affect our daily activities, leading to things like loss of independence. There was a study that came out that actually tied poor vision with increased falls, leading to actually death because of fractures from the hip. So this stuff is real, and it's important that we make sure our patients who are over the age of 65 have good vision. Also, for example, if our vision is being affected, we may not be able to feel safe driving. So then we may stay at home, become more socially isolated, which we know is related to depression. So all of these are kind of outside of the box that we think of. The vision thing is pretty clear, but the secondary and the tertiary effects of poor vision kind of highlighting that. And if we look to the leading causes of visual loss in the population that's over the age of 65, we can see here we have age-related macular degeneration, glaucoma, cataracts, and diabetic retinopathy. And so just want to highlight, not only is the third most common cause of vision loss a cataract, but this is actually a reversible cause of vision loss. So once we have cataract surgery, we're actually able to restore the vision loss. With these three other conditions, the importance here is to catch them early, because if we can catch them early and manage them, then we can prevent losing vision to them. But once you lose vision to these conditions, right now there's not really much to bring the vision back. And so that's kind of the other huge thing about cataracts, is that it's a reversible loss of vision. And if you're interested in learning more of these other topics, we do have other community lecture series that do focus on these. So just stay tuned and make sure you're on our email list to get information about those topics. So, looking at cataracts, it is a public health issue. And, it's more than just quality of vision. If we look at things like for every 100,000 miles driven in our adult population, vision is related to a higher crash rate, especially in the over age of 65 group. We also have to factor in there that people who are over 65 are actually the fastest growing group of drivers that we have in the United States. And if someone gets in a car crash and it's due to a visual disturbance, loss of vision, they're more likely to suffer a disabling condition or even die from the car crash. And most older adults actually, believe it or not, are driving on the road right up to their time for cataract surgery. And just to kind of take this point and make it stick in your mind, this is actually a patient of mine who came in for their cataract surgery measurements a week before their cataract surgery. And she was using her backup camera and didn't realize in the garage, and basically drove off the edge of the parking garage. So this is real, and really does affect our quality of vision. So kind of once again, connecting this all, driving is really important because especially in Southern California, this is the primary mode of transportation. It's a symbol of independence. And so we do know that if patients are not able to drive because of their vision or their driver's license is taken away, it is related to depression and social isolation. And so this is kind of where we need to balance, safety, but then also, consider the need for personal mobility. So our goal really is to optimize vision as soon as symptoms from cataracts, such as glare or blurred vision, occur, to kind of make sure that our patients are able to continue being active drivers and drive safely. And so once again, just these are some photographs to demonstrate to you, because it's really hard for me. I can say what a cataract is, but to kind of show you. So when we're talking about reduced contrast, you can see in this photo here, there is a child in the middle of the street. And so someone driving this car can tell there's a child here playing and push the brakes. But someone with contrast loss due to cataract, overall the vision is bleached, and so it might be difficult to make out that there's actually a kid here, and this is where we could be causing some injury. And like we talked about, one of the most common initial presentations of a cataract is nighttime glare and halos. And so a little bit of a halo or glare around lights, this is okay, this is tolerable. But as a cataract gets worse, these glare and halos actually block vision and make it unsafe. And so we can actually do testing in clinic to see how much the glare is reducing vision in our patients, to help our patients make the decision of when it's time to do cataract surgery. We kind of hate on this, but cataracts do elevate crash rates in older drivers. And there's a study here that showed that patients that underwent cataract surgery, their overall rate of having a cataract was, I'm sorry, of having a car crash was reduced by 50%. So if only we could get a discount from our car insurance company if we had our cataract surgery. But the data is there if anyone wants to take this on and try to fight this battle. So moving on, what are some of the preoperative assessments that are important when it comes to cataract surgery? Well, first of all, we need to make sure our patients are healthy enough. So that includes complete medical and surgical history. Things in particular, patients who, have a cardiovascular history or have cardiovascular disease. Among other things, we need to make sure that they are healthy enough to undergo surgery and anesthesia, as well as some labs that can help identify that. And so this is where we definitely want to make sure that our patients are all cleared medically for surgery by their primary care doctor. It's also helpful to have a record of visual acuities, so past visions, and also the glasses prescription. So that way I can see how the fastest cataract is progressing and, when help to make that decision of when it's time to do the cataract surgery. Obviously, we want to perform a detailed examination of the eyes, and then also use high definition imaging. This can, not only help us determine the overall health of the eye, but as part of cataract surgery, which we'll touch on in a few slides, placement of an intraocular lens is important because, like we talked about when we're younger, that lens, when it's not hard, when it's not yellow, is involved with focusing and accommodation. So it's actually involved with about a third of our vision. And so if we take the cataract out and we don't put something in its place to help us refract light and see, then vision is going to be very difficult. And so this is where that imaging comes in to kind of help customize and make sure we have the correct power lens that's going to go with the eye. Because ultimately that lens, the goal is that it's going to stay with you for the rest of your life. And then it's really important that our patients are educated about the surgery, the plan, the lens, what options they have, the risks, which most of which we'll cover this evening. And then lastly, we need consent. So it's something that this is an elective procedure. Obviously, still though it's elective, we need our patient's permission to proceed. And you can't give consent unless you understand the risks, the benefits, the indications, and all alternatives for the procedures. So moving on to cataract surgery, big important thing here. It sounds scary, but 99% of cataract surgery is done under topical anesthesia, meaning that our patients are awake. They're receiving IV sedation by an anesthesiologist, so they're comfortable and they're relaxed, their eye is numb, but it's not high-risk general anesthesia where, our patients are being intubated or being put to sleep completely. Now, we do have the option for general anesthesia, but we tend to reserve this more for more complex cases. For example, when a cataract is in a child, an adult who just cannot lie still, or inability to know what's going on during the surgery. So, for example, someone who has dementia. So once again, options there. However, risks go up anytime we go from IV sedation to general anesthesia. The surgery itself is not long. Technology has really moved us so far ahead that a routine cataract can take anywhere from 6 to 15 minutes. So yes, there's a lot involved in the surgery day. It takes about an hour at least to get our patients ready. Even once they're in the room, there's a lot of prep and setup, and then after the surgery into the recovery. So even though the surgery itself is a 15-minute procedure, the whole visit could take up to 3 to 4 hours from when our patients walk in and get to go home. And so the important thing is if it's possible for our patients to come off their blood thinners, that's always great. But this is not a contraindication for us not to proceed with cataract surgery. As long as our patients understand, they're more likely to bleed more. So for example, their eye might be a little pinkish red if they can't come off their blood thinners. However, this is not a reason that we can't do the cataract surgery. So continue on here. These are kind of the steps, just briefly wanted to go over what cataract surgery is to help you understand, what the process is and what's going on. I am going to share some surgical videos, so if you get a little cringy from eye surgery, you may want to look away during those, but all this stuff is online and on YouTube. Not something that you couldn't find yourself if you were interested. But basically, everything is done through a microscopic incision. The incision is roughly about 2 millimeters. And then we need to make a circular opening to the cataract. So this is where we use some fine forceps to make a circular opening to the cataract. And then we use a handpiece that uses both fluid and ultrasound that very gently and microscopically breaks the cataract up into small pieces and removes it from the eye. So you can see here we're basically cutting it up microscopically like a pie, removing those segments. And then after that, there is a very thin lining of the cataract that we call the cortex, which we use a different handpiece that just uses irrigation and aspiration, and we peel that off almost like a layer of an onion. But our goal here is we want to preserve the capsule of the cataract. So basically what the cataract is in, because that's what our implant lens is going to go into and stabilize and become part of the eye. So you can see here, then after that, we place that implant lens in the capsular bag. It becomes part of the eye, and basically the eye itself heals to that lens and it stabilizes for the most part, usually by a week. So for those of you that are a little queasy, you may want to close your eyes for the next minute, but this is just kind of showing you what cataract surgery, what's involved. So here's our microscopic incision. After this, our patient has received anesthesia at this point, but injecting some topical anesthesia. So basically numbing the eye, that's what that was. It just went in. The next step is we want to make sure the eye stays inflated during the procedure. So we have this jelly that we place to kind of keep it that way. This is our secondary incision here, just because, having two hands makes the surgery much easier. And then the next part is making that opening into the cataract. So making a microscopic puncture in the anterior capsule of that cataract, and then trying our best to kind of then open it and make a nice circular opening. You can see here just a very thin membrane, and the cataract is behind that. And then as much as possible, we want to try to keep this circular as best we can, just kind of helps our outcomes. And then after that, just using some fluid to just loosen the cataract in that bag, because once again, we don't want to be traumatizing the support system of the cataract. We want that cataract to be mobile in that bag so we can remove it, but preserve that bag. So you can see here, I can easily rock and rotate that lens. And then after that, using that ultrasound handpiece here to just basically almost like a pizza pie, just chop this cataract into small pieces and segments and then remove them. So the space is very small. So it is a delicate surgery. However, we respect the anatomy. And when you've done thousands of these, the surgery, that's how it ends up taking 6 to 15 minutes. So you can see here, we've already gotten a third of the cataract out. This surgical video is not sped up, so it's kind of real time here. And then here, continuing to remove it. So for time's sake, just kind of going to forward ahead here. So at this point, we've got that cataract removed. We've got that nice opening to that capsular bag. And so next we'll be inserting that lens. This lens is custom for this patient's eye. It's folded like a taco, so it goes through that microscopic incision, and then it unfolds into the capsular bag, and you'll see here it goes into position very nicely. And then last step here is just removing that jelly that was helping keep the eye inflated from the surgery. And that's basically cataract surgery in a nutshell, at least conventional cataract surgery. So, we talked about different intraocular lens options, or we talked about intraocular lenses, but it is important to discuss that our patients have options. So, insurance does cover a standard monofocal intraocular lens. What this means is that this lens, without correction, can have one focus point. So, we can basically set the focal point of the eye for distance, and then our patients will need glasses for kind of intermediate up close and astigmatism. Or we can set it for up close, so our patients can read without glasses, but then they're going to need distance glasses. If our patients don't have astigmatism, potentially with a standard monofocal lens, we can do something called monovision if that's something our patients have tried, where one eye is set for distance and their non-dominant eye is set for more up close work. And so that way they can get by doing distance and up close without glasses. However, this is something that our patients haven't tried before. After cataract surgery, where it's likely going to be permanent, is not a good idea. Now that's on the standard side. Technology has advanced that we actually have premium lifestyle lenses. These lenses can help reduce dependence on glasses. And so a few of them that are available. One is a multifocal lens. So this lens gives multiple focus points. So the latest multifocal lens actually gives three focal points, one at distance, one at kind of intermediate, like computer screen, and a little bit closer than intermediate. So not complete working vision, but three strong focal points where we do the vast majority of our work. There's also an extended depth of focus lens. This lens gives a good focal point at distance with a range to intermediate, so like computer screen out. Now, between the multifocal and the extended depth of focus, anytime you're gaining independence from needing glasses or contacts, you do potentially give up a little bit of contrast. For the most part, our patients tolerate these lenses well. However, in the literature, it's about 10 to 12% of patients, more so with a multifocal, that may see a little bit of a ring or halo around lights, especially at night. So that is something to think about, the pluses and minuses. Now, one of the latest technologies that we've had come available in the last few years is the light adjustable lens. This lens has been a game changer in that this is a lens that we implant in the eye, and then after the surgery, without having to do any sort of surgery with a light procedure, we can actually adjust the focal point of that lens and now allow our patients to kind of customize where it is they want their focal point. And then lastly, we have a toric or astigmatism correcting lens. So astigmatism is different than a cataract. It has to do with the shape of the cornea. And so if the cornea is not completely spherical in all of its meridians, it's more, for example, pointed, then we'll have astigmatism. And so that can affect quality of vision, for example, edges of things looking blurred or looking oblong. So this is different than the cataract. And so if this is not corrected at the time of cataract surgery, another reason why patients may need glasses or contacts. So this is just an example to just show you the progress of the eye going from, healthy eye being able to see far away and up close to, as we get older, the normal maturing process of the eye, presbyopia, where we basically lose the ability to see up close and read without glasses. Then kind of showing, what cataracts are like, how that affects the vision, and then the different lens options. So the monofocal lens, showing that, if it's set for distance, a multifocal lens during the day, and then showing what those potential light aberrations could be with a multifocal versus the standard monofocal lens. So you can see here, healthy eye, able to kind of see distance, intermediate, up close. As we get older, you can see the cell phone starting to get blurry. So difficulty with up close, intermediate reading. As the cataract kind of sets in, things look yellow, colors, contrast being affected. Now kind of showing that monofocal lens, things far away, clear, up close will be blurry, with a multifocal kind of potentially getting the three focal points. And now transitioning to nighttime, driving with the monofocal lens, can't see up close, but no issues with far away. And then with the multifocal, potential for these halos around lights at night, but being able to have all three different focal points available without glasses. So once again, we kind of hit on this. These are kind of what these lenses look like in real life. The light adjustable lens, so this is by a company called RX Sight. And so the lens is implanted with UV light. Basically, we can make polymers in the lens and change the shape of the lens and affect the focal point without actually having to remove or change the lens or do any sort of surgery. The caveat here is these patients, until this lens is locked in and our patients are happy with their focal point, they do have to wear special UV protective lenses, especially when they're outdoors in the sun, just to kind of potentially prevent any sort of rays from the sun that could prematurely cause any sort of polymerization of the lens. But all in all, patients are very happy with this lens, and it gives us as surgeons the opportunity to our patients to tell us what they really want and what they are able to tolerate and like. So when we're talking about the astigmatism lens, just showing you astigmatism, this is kind of like a elevation map of the cornea. So you can see kind of in this meridian, there's an elevation on the top and the bottom of the cornea, kind of looks like a bow tie. This is regular astigmatism, and astigmatism correcting lens, if placed in the eye, will correct for this. We can see here, this is a little bit irregular. This is regular, but some changes in symmetry. So this one, potentially astigmatism correcting lens would work, but then we have completely irregular astigmatism. In this case, an astigmatism correcting lens would not be a good option. That's where, some of the more recent lenses that became available, such as a small aperture lens, may be a good idea. Someone who has keratoconus, or that's mild, or prior RK. In their non-dominant eye, this is basically like a pinhole lens. So allowing to make up for those aberrations coming from those irregular corneas. This lens as well is not covered by insurance. It's an out-of-pocket cost, but it's really tailored for a specific population of patients that would benefit from this. Now, moving on to technology, how it's advanced cataract surgery. Well, now we have femtosecond laser cataract surgery. So this is where a laser helps and does a good chunk of the surgery before we've even started. And it's a very fast laser. This laser can help soften the cataract before we started the surgery, make all the incisions, treat the astigmatism, make the opening to the cataract. And there's multiple different platforms that are available. And so just kind of here to show you real life, that opening that we made that you kind of saw with that forceps, the circular opening, well, this is staining of that capsule with a hand cataract surgery versus with a laser. So you can see here, yeah, these are pretty circular, they're pretty consistent, but not as circular and consistent as when it's done with the laser. So we get that extra precision when we're using the laser. So that's that. It can help soften the cataract. So even before we've started, the cataract is softened, making the surgery itself a little more easy on the eye itself and speeding up healing. We're able to do treatments to treat the astigmatism with the laser, and then make 3D incisions as well. So we don't have to use blades, just use a laser. This is another video here just kind of to show you how fast this is. So this is the laser part of the surgery. You can see it's going to make that circular opening in a few seconds. Now it's softening the cataract. It's going to make a nice kind of like waffle cone pattern. So this way, during the cataract surgery, less energy is needed. And then it's going to proceed with making the astigmatism corrective incision, and then the actual incisions for the surgery itself. So you can see here, pretty quick. We're almost halfway done with this part, and it's only been, like 20, 30 seconds so far. So all in all, we're talking about 30 to 45 seconds for this laser part of the procedure. But this really does help speed up the surgery, make it less traumatic on the eye, and potentially speed up healing as well. Laser cataract surgery is not covered by insurance, so it is an out-of-pocket cost. But here, I think you can see where the benefits come in with using the laser. And another surgical video just showing you a cataract that's been kind of pre-softened by the laser, how much faster and less traumatic this is on the eye, but pretty much same from this part out. Now, when it comes to after the surgery, our patients, commonly either go home with a shield or not. My patients all go home with the shield, and I ask them to wear that clear shield for 24 hours so they can see through the eye, but it's just kind of a reminder to like not bump the eye. And then after that first day, I ask them to wear that shield at bedtime or when they're napping for the first week. And that's just, once again, to protect the eye. We do start eye drops after the surgery. For the most part, most people are still using eye drops. There are some locations that will do an injection of a medication at the end of the surgery to limit the amount of drops. However, that in itself does have some potential side effects or indications that should be considered. We keep our patients on antibiotics, antibiotic drops for 1 week, and then anti-inflammatory drops that are tapered over 4 to 6 weeks. I commonly taper them over 4 weeks. A restriction to kind of consider after cataract surgery is that not to be doing any lifting, really more than 10 pounds for the first week after the surgery. We only do, for the most part, one eye at a time, and then usually patients space those out by a week. So kind of just a reminder there, it's really going to be 2 weeks. There are considerations for patients having cataract surgery of both eyes done at the same time, but just kind of a reminder there, anytime there's potential risks, we like to kind of contain it to one eye instead of potentially opening up both eyes. But there are situations where we will do cataract surgery on both eyes at the same sitting, but for the most part, we separate them out. We also ask for that first week, our patients are not bending past the waist. Anything that's going to increase that intrathoracic pressure in the chest, that can come back on the eyes. So bending past the waist to pick things up as well, having our patients refrain from that. We talked about wearing the shield at bedtime. And usually the post-op visits, I see my patients the next day, and then usually about 2 to 4 weeks after that. And then by 3 months, we're kind of done there, and kind of spacing this out if both eyes are done at the same time. So let's talk about some real stuff. Cataract surgery, it's an elective procedure. Any medical procedure has risks. There's no such thing as a risk-free procedure. But for the most part, cataract surgery, the success rate is very high, 97%. Cataract surgery is the most commonly done surgery in the United States. And if you compare it to other procedures, I don't know of many that have a success rate of greater than 97%. Although complications can occur, they are not common. They're rare. For example, something like infection, if you look at the literature, can happen anywhere from 0.01 to 0.15%. And this is something that our patients really can pick up quickly. So this is something usually if it happens around 3 days after the surgery, a drop in vision. So our patients are noticing first their vision is clearing up, it's getting better, but then all of a sudden now it's getting blurry, they're having pain, their eye is red. These are clear things that our patients would know and come in. And if we can start treatment early for the infection, we can usually limit and mitigate any sort of permanent effects. Another common thing that can happen after cataract surgery would be that the eye pressure goes up. This is why we see our patients the day after surgery to check the eye pressure. And if the pressure is going up, we commonly will start an eye drop to help lower the pressure. And for the most part, this is transient. It's not like a chronic thing that happens for the rest of their life. But usually by the time the post-op period is done, our patients no longer need to take those pressure drops. With someone who's not had any sort of previous retinal history, like a retinal tear, retinal detachment, there is a potential for increased risk of a retinal tear or a retinal detachment after cataract surgery. But you can see here it's very low, 0.01 to 0.02%. And the reason is if you saw that cataract was taking up space in the eye, so we take that cataract out and we put a thin lens in the eye. And so there's some potential for the jelly from the back of the eye to kind of move to fill in that space. And that process can cause some tugging of the jelly or the vitreous on the retina, initiating a retinal tear. Once again, not common, but these are the reasons why we follow our patients in the post-op period, monitor for this, and make sure our patients are aware of potential signs of this starting to happen. Although it's not a complication, there is something called posterior capsular opacification. So this is where, after cataract surgery, we place that lens in the capsular bag that the cataract was in, the eye heals to it, but over time, the back of that bag starts to stick to the center of the lens, almost like a fingerprint, creating some haziness and affecting our patient's vision, and slowly that progresses. The good thing is that we have a laser procedure we can do in clinic. It takes about a minute or two. It's not invasive, where we can clear out that membrane and then the vision goes right back to what it was right after the surgery. So here kind of showing you, visualizing what I'm talking about. You can see here after cataract surgery, this implant lens, crystal clear, but over time we're getting some areas where the back of that bag is starting to stick to the lens. You can see here with grade 3, you can see that where if light was to hit with this, it could create some glare or cause some blurry vision. Grade 4 is pretty significant here. But this is where we can do that laser procedure that's covered by insurance, clear it up, and the vision resumes back to what it was. So here, just kind of trying to demonstrate what that machine, it's not invasive. It's almost like getting an exam. our patients, they put their forehead and their chin in the chin rest, and then the laser kind of clears it. We do have a contact lens we can place on the eye to kind of help immobilize the eye and keep the eye from blinking. And then here you can see after it's been lasered, outside of this is kind of that old membrane that was affecting the vision, but now the central part of the lens is crystal clear after this is done. So one of my last points I wanted to hit on was another kind of important topic, especially here in California, but how this relates to cataract surgery, and that's the impact of dry eye disease and ocular surface disease when it comes to cataract surgery. So dry eye is the leading potential error when it comes to postoperative measurements not lining up correctly. Because dry eye can affect the mapping of our cornea and our measurements, it can ultimately affect our outcomes. Also, in an eye that's dry, it can potentially increase our risk for infection. And we know that surgery is going to get worse dry is going to get worse after surgery. And so ultimately, all these things can come to the situation where our patients are just not happy after surgery. For the most part, it's not that the surgery is causing dry eye, it's that dry eye as a baseline is pretty prevalent. And so that the surgery actually overthrows that dry eye, makes it worse after the surgery, and that's when our patients are noticing it more. So this is why it's really important that you go to somewhere where dry eye is going to be screened for. If it's detected, it's going to be treated and managed, and then until it's improved before getting measurements, and also just monitored afterwards as well to make sure it's not getting worse after cataract surgery. And so here are just some data sharing it with you. 60% of routine cataract patients had dry eye. They were asymptomatic. So, that's quite a huge amount that had dryness and they didn't even realize it. And so of those, 50% actually had clinical signs of severe dry eye. And if we're talking about patients that are showing up to be worked up for cataract surgery, 80% had some sort of sign of ocular surface disease. And even if we're looking at the asymptomatic patients that came in and they didn't even know that their eyes were dry, 50% of those have abnormal testing that we routinely do at UCI. So that's something we would pick up before proceeding with cataract surgery. And when it comes to treatment, this is a whole topic and lecture in itself. We have a lot of options when it comes to treating dry eye. It's trying to target what's going to work best for the type of dry eye our patient has. Additionally, if our patients are coming for cataract surgery, they want to get their condition, they want to get their cataract surgery taken care of soon. And so with patients coming in for cataract surgery, probably going to be a little bit more aggressive. Instead of trying one agent and seeing what happens, try a few different eye drops, few different medications to get the surface optimized so that way our results have improved and we can get good measurements and also keep that stable in the postoperative period as well. So in conclusion here, cataract surgery, most common in surgery in the United States, outcomes are really good. Potential bad outcomes are low. And there's a high chance that our patients can return to normal visual function relatively quickly after cataract surgery. This idea that, previously I've heard by many of my patients who've been monitored for cataracts that the cataract needs to be ripe to be taken out. I think no longer this is not something that we use. We're going to proceed with cataract surgery when our patients are symptomatic and it's affecting their quality of life for many of the reasons that I've highlighted in those slides, whether it's driving or mobility, so our patients are safe and can do what they need to do. We also reviewed the different intraocular lens options. The great thing is that we have so many options that we have available that we can kind of really customize for our patients, so that way they get the outcome that they're looking for. Also hitting on the importance of getting screened for dry eye disease, and if it's present, to get it treated aggressively before proceeding with cataract surgery, and really approaching our dry eye patients who have cataracts in a more aggressive manner to get the dry eye optimized before we proceed with cataract surgery. Because the last thing we want as a surgeon is to turn the asymptomatic dry eye patient pre-op into the symptomatic dry eye patient after the surgery, which I'm sure you've probably heard from many patients who've had cataract surgery and talk about dry eye after. It's real, but it's something that we're realizing is present before cataract surgery, but patients are commonly it's worsening after the cataract surgery.
That's great. Thank you so much. We will be sure to send this lecture out as soon as we have it, usually within a week or so. If you'd like to join us for any additional events, feel free to register on our website, ophthalmology.uci.edu/events. Thank you all for joining us, and thank you so much, Dr. Behshad.